Okay, good afternoon. I'm Chris Comstock from Sloan Kettering. I have a bit of a confession. I'm listed as a foreign speaker, but I'm half British. My mom, or I should say mum, is from Blackpool, so it's nice to be back in England. I'm going to just talk a little bit about the future directions of breast MR and this concept of abbreviated breast MRI. So this is our this is the main hospital in New York. We're in Manhattan on the Upper East Side, and that's the main hospital that sees all types of cancer. But we're actually a few blocks away in the Evelyn Lauder. This is just for breast cancer, so it has the radiologists, the surgeons, oncologists all in one building. In the United States, the recommendations for screening mammography has held steadfast for quite a few years. Obviously, there's been quite a bit of debate in the 40 to 50-year-old age range, but still in the United States, I know, unlike the UK, the American Cancer Society, the SBI, various other organizations, American College of Radiology, recommend to women to start screening mammography at age 40 and continue as long as they're in good health. And we know from the 8 randomized control trials from many years ago showing the benefits of screening mammography. And mammography is really, in terms of mortality studies, the only test shown to reduce mortality from breast cancer through annual screening. Now, there was one outlier, the Canadian study, that failed to show a benefit. This has been reviewed and commented on for many years. And that study, the Canadian study, had several major flaws. One was the technique of the mammographic images. Martin Yaffe was the physicist, and he himself, he was the physicist for the study, says that, that the studies were suboptimal quality. And also, the randomization was done by nurses in the Canadian system. And when a patient had a palpable lump, they were concerned, so they tended to try to put them in the arm that got a mammogram. So that flawed the randomization, where you had palpable cancers, which are going to be advanced cancers, put into the screening arm. So that's really the only outlier, but I think most people accept these studies as showing the benefits of mammography. Now, you have to remember that since those randomized trials, those were done on either single-view mammography, they were done on older technique. Since those studies, we've seen improvements to mammography, including improved screen film techniques, CAD, digital mammography, and now tomosynthesis. So the assumption is that there's even more of a benefit from screening mammography with these improved techniques compared to those original randomized control trials. We've seen one big advance that's becoming the standard in the United States as digital breast tomosynthesis. It's slowly becoming the standard. We have probably, out of our 14 mammographic units, I think 8 or 9 have tomosynthesis capability now. So how much has tomosynthesis improved mammographic screening compared to digital and analog? It's not a big improvement. This was a study in JAMA published by Sally Friedewald, who's the section chief at Northwestern in Chicago. And they compared 13 sites, almost 500,000 women, the performance of mammography, digital versus after the adoption of tomosynthesis. And you see that they went from about 4.2 cancers per thousand to an extra 1.2 cancers per thousand detection, and they decreased their recall rate. Now, I know in the United States our recall rates are significantly higher than in Europe, but it did reduce recall rates. So it's the consensus in the United States, and in the words of Dr. Copans, tomosynthesis is it's a little bit better mammogram, and it's slowly becoming the standard. But we still know, even with tomosynthesis, that mammography sensitivity is dependent on breast density. And the more dense, obviously, the less sensitive mammography is going to be. This is just some data from the Breast Cancer Consortium, which showed that the more dense the tissue pattern, then obviously the lower the sensitivity. And this is just a case here of a dense mammogram, and with MRI, we clearly see the cancer. Here's a I don't have the slices through the tomosynthesis part of the study, but this was a tomosynthesis study that was read as negative. The patient had positive nodes, and this was looking for the primary cancer. and it was not seen on tomosynthesis, because even though tomosynthesis is an improvement, it still relies on morphology and seeing the margins of a lesion. So if a lesion is buried in dense tissue with no fat along any of its margins, it won't be detected. It's still morphology based. And here was the MRI in that patient, which clearly shows the cancer without any difficulty. Now, something that's come about in the last 5 or 7 years in the United States is some laws passed in multiple states called breast density legislation. And it was due to the shortcomings of mammography, where we had a congresswoman or a congressman's wives or women complaining that they went to their doctor, they had a lump, and they got a biopsy and they were told it was a cancer, and they said, wait a minute, I had a mammogram 2-3 months ago. So why did it miss that? So we had this grassroots movement in the United States, and it created these laws where a patient has to be notified when they have a mammogram if they are in the top 2 categories of BI-RADS densities, so C and D, heterogeneous or extremely dense. They get a letter at the time of their screening that says that they should talk to their primary care physician about supplemental screening, and that their mammogram may be limited, and they're at a higher risk for breast cancer due to that. It doesn't mandate that they have the screening. It doesn't say what type of additional screening they should have. Here's just a map there's a website in the United States called Are You Dense? And it was this grassroots movement, and it's now in about 37 states that mandate. The tricky part in the United States is that although they get this letter, only a few states require insurance to cover that extra screening. So the patients are kind of left in a difficult position. So how many women, at least in the United States, fall into where they would be getting that letter, being told that they have dense breast tissue? It's about 50% of women that are in the top 2 categories here. And so we've seen a vast proliferation of supplemental screening with whole breast ultrasound. And why did ultrasound become the default test? Well, it's available, it's relatively known to the referring family medicine and gynecologists, and it's fairly low cost and can be done on a mass screening population. We know that the data, at least in terms of high-risk patients, is about 3 to 4 extra cancers per 1,000, but in the intermediate to average risk women with dense breasts, it's only about 2 to 3 cancers per 1,000. The problem with ultrasound is it has an extremely low PPV, about 8 or 9%. It's got a high frequency of short-term follow-up recommendations, and it's fairly time-consuming. There was a study in the United States where the radiologist, the Wendy Berg whole breast screening ultrasound study, in that study, it was 19 minutes of radiologist time to scan, which is just not really feasible in today's workforce. In Sloan Kettering, we did maybe 2 or 3 screening breast ultrasounds a day. When the law passed in New York, we now do 30 to 40 whole breast screening ultrasounds a day. So we've had a dramatic jump in women with dense breasts getting whole breast screening ultrasound. So in the United States, for a significant number of women, the current standard of screening, and I know it's very different than the UK or Europe, is there's a large number of women who get annual mammography, either digital or tomo, and whole breast screening ultrasound. And that's a fairly significant cost, $200 to $300 to $400 annually per patient. With this program of screening, we probably detect about 7 to 9 cancers per 1,000. We haven't done any mortality studies compared to those original randomized studies, but our assumption is that finding more cancers is better. But the one thing, and I didn't mention this about tomosynthesis, is that in our current thinking, in the past we've always just counted cancers, but there may be something different in the modalities, ultrasound, MR, mammography, and tomosynthesis. They're detecting maybe different types of cancers, some cancers not as important as others, and we know tomosynthesis is very good at seeing spiculated masses. Well, those tend to be lower grade, so if tomosynthesis is finding more cancers, does it equate to a linear improvement or reduction in mortality compared to the original screening studies? And the answer is probably it's not linear because they're not biologically as significant. And it's a very high cost and it's a low PPV from the screening approach. So When I took over the Akron Breast Committee, so Akron, American College of Radiology Imaging Network, is where the DMIS study came from. Etta Pisano did about 50,000 women comparing analog to digital. Wendy Berg did a study comparing, looking at whole breast screening ultrasound. And Akron was created because in the radiology at the NIH, they saw that the oncologists and surgeons are very good at doing multi-center studies. NSABP and all the different cancer studies and therapy studies. But radiology really relied on single institution papers and studies. And so Akron was created as a process, as an organization to do multi-center trials. And so when I took that committee over about 5 or 6 years ago, I wanted to look at future directions. And I brought Christiana Kuhl and Gillian Newstead on board because I really thought we needed to expand the use of MRI. And if you look at, this is Wendy Berg's whole breast screening ultrasound study published in JAMA, which was about 3,000 women, and then they did, who had 3 years of negative ultrasound and mammograms. And they did one, she got funding from Avon for a single round of MR, and the MR found 15 extra cancers. Not 15 total, but so compared to 11 per thousand in women getting mammography and ultrasound. Now these were women not high risk, there were some gene carriers, but they were intermediate to high risk. They had dense breast tissue in one quadrant. We don't have genetic modeling on them to know the exact risk, but they were higher risk and dense. But this still says that for every 11 cancers you find while you're working every day, reading all those screening ultrasounds and mammographic studies, 15 cancers walk out the door. Okay, and the total detection here was 26 cancers. So if you took out ultrasound, mammography found about 7 out of that 26 cancers. So it's hardly 25% sensitivity. So, so can we use our MR, our most sensitive test, which is based on finding cancers from vascularity rather than morphology, rather than seeing the size or the margins of the tumor, but looking for the vascular changes. I don't have time in this lecture to talk, but we are doing contrast mammography. We do about 5 or 6 a day, and then we also do several as part of studies. And it's another contrast vascular-based study which has promise. Here's just an example of a cancer that would never be detected with mammography or ultrasound. This is a patient with dense breast and actually injected silicone to make it even more complicated. And here's a clearly, easily detected invasive ductal. So MRI, the benefit is it's not limited by breast density. It doesn't involve radiation, ionizing radiation. It's the most sensitive test. It does have a PPV similar to mammography, and when you have a comparison study, not the baseline always has, false positives, but when you have a comparison, it's even better than mammography. And it preferentially detects lesions. It may find cancers that are biologically different than mammography. This is a study from in radiology, I think in 2016 by Janice Sung. We have about 5,000 MRs a year that we do at Sloan Kettering on high-risk patients, and they get combined screening, mammo and ultrasound. So Janice looked at what types of cancers the two modalities were detecting in these high-risk patients who were getting both screens. And you can see that the mammogram clearly detects lower grade, this is lower grade DCIS, where the MR finds everything, but it preferentially detects higher grade type cancers. So there's something that we're looking at, what we call the biological detection profile of a modality. Okay, and it's a change from in the past where we just counted cancers. So why have we ignored breast MRI? At Sloan Kettering, if a patient comes in and it's not covered by insurance, it's about $4,000 to $5,000 out of pocket for an MR, so it's very limited. Because of the cost, the time, and the perceived low PPV, we in the United States follow the American Cancer Society guidelines, where it's only patients with a greater than 20 or 25% lifetime risk based on either BRCA Pro or Klaus models, or they're a gene carrier or a first-degree relative of a gene carrier. So it's a very small number of women. And so this concept of how do we increase access to our most sensitive test. And so this is where this concept of an abbreviated MR, it's very arbitrary. We want to get the cost down to about $300 to $500, where it's similar to ultrasound screening. And if it has such a higher detection rate, it's something you don't have to do annually. So you could do it every 2 or 3 years, and that way the cost is even less. And so this is just a cost comparison of if you did annual whole breast screening ultrasound, you did a $300 MR, versus a $350 MR every other year, it's actually less costly than it is to do ultrasound every year. Let me just back up. So what is an abbreviated MR? Well, and why does 10 minutes work? Well, in terms of reimbursement rate, if you do 3 patients an hour, so 10 minutes per scan, plus they have the table on, table off time. At a 10-minute scan, you can do about 3 patients per hour. And if you're doing that at about, let's say a normal MR is $900 or $1,000 reimbursed from our Medicare programs. If you did 3 patients, you could get the cost down to $300-400, and still your MR magnet time would be making the same amount of money, but you've increased access. So, how do you get an MR down to 10 minutes? And really, what's the most important part of a breast MR? It's a pre and a post. It's just the detecting what enhances. Right now, the time in our scans is doing the multiple posts to look at kinetics. So the only penalty you do from, and I know I've had some heated debates with Christiane in our trial design, but she likes to just do a pre-post and read the MIP. But in the United States for our trial, we wanted it to be a little bit still more familiar as a regular MR was, so we kept in the T2 scan. So our abbreviated MR is a T2, a pre, and a post, and obviously a localizer. So it's less than 10 minutes to do those. And what do you lose? So if you lose kinetics, the only place you might take a penalty is if you had a cancer that was totally benign looking, smooth, internally it was homogeneously enhancing, and you said to follow it, but had you had the kinetics, it showed washout, you would biopsy it. And so there's a small loss of sensitivity, but it's pretty uncommon that you have a cancer that is so benign looking that the kinetics is really the only way you detected it. So maybe it's a 2, 3, 4% loss. But then you've saved a bunch of time and you've maintained pretty closely the sensitivity. So that's the concept of an MR, is just a pre-post and a T2. So we embarked on a study, really, so we wanted to do a phase 2 type study where we looked at the performance of this abbreviated MR compared to tomosynthesis. Now, a lot of people ask, why didn't you compare it to tomo plus ultrasound? There's so many studies and so much data. We pretty much know the number of cancers that ultrasound will detect. It's probably 2 to 3 in this population. And it complicates the study when you have patients in a research study getting multiple 3 tests instead of 2. So we embarked on this study. It's about a $4.5 million study. The co-investigators, Christiane Kuhl and Gillian Newstead, to look at just phase 2 data of this 10-minute MR. And so the primary objective is just to compare the invasive cancer detection rates on the first go-round, okay? I won't go into all the details of the second. And it's a paired design, just like the whole breast screening ultrasound study, where every patient gets both tests. So these are women who are age 40 to 75. They're scheduled for a routine screening tomosynthesis. They have no symptoms. They're not on chemoprevention. They're just routine screening. And they're getting a tomosynthesis as ordered by their doctor as their annual screen, and they volunteer to do the 10-minute MR. And those are read by 2 separate radiologists, blinded. So the whole goal is just to look at the detection rates of the 2 studies. We're counting all cancers, but the NCI, when we went through the NCI to get the study approved, their big concern is overdiagnosis. If you may find a lot more cancers with one test, but is that overdiagnosis? Are you just finding a lot of insignificant cancers? And so in order to address that, we geared the study, powered it just to invasive cancers. And they even argued that some invasive cancers are overdiagnosis and overtreatment. I think that's a little extreme, but you might say that about some low-grade DCIS, but not invasive cancers. So we powered it to, and here's the schema where the patients got randomized. Now, the randomization isn't part of the analysis. The only reason we put in the randomization here was so that we didn't end up with equal, let's say at the end of the study, for some reason, because of scheduling, that 80% of patients had their tomo first and then their MR. And people would say, well, the person reading the MR could peek on your PACS workstations and see the results from the tomo. So we wanted to prevent any bias, so we randomized them so there's an equal number of women who get the tomo first and then the MR, and then the other arm is the MR and the tomo. But that's the only reason for the randomization. They get a baseline, and then they get one at 1 year. So they get 2 MRs in the same order, that they were randomized. Because really, to look at the performance of a test, you need to see how it performs not just on the prevalence screen, but on the incidence screen. And our prediction is, the first screen is going to have a significant number of biopsy recommendations. The PPV won't be super high. You can have BI-REDS 3s. But on the next, when you have a comparison MR, I think the performance going forward with this abbreviated MR is going to be much more efficient. And so that's why we wanted to do a baseline and a one-year MR. Then they go back to their routine screening. And we watch them, and whatever their screening program is, maybe they go back to ultrasound and mammography or tomo, but we watch them for 3 years. And why do we do that? Because if we've swept out a significant number, twice as many or 3 times as many cancers, when they go back to their screening, their incident rate should be low. They should be not finding very many cancers, and then it'll creep back up. So that's why we put that follow-up in. We had a mixture of sites. They had to have training on reading the abbreviated. They had to pass a reader test for the abbreviated MR. And we also had some interpretation guidelines to try to standardize interpretation of how you, with foci, when do you biopsy, when do you follow, masses, and non-mass enhancement. Now, we couldn't force them, but these were guidelines we hoped they follow, but it tried to standardize the reads a little bit. It would be like in a drug study, if you gave every site the drug and one site gave it 3 times a day and another gave it once a day and different. So, that's the problem with radiology is you need to try to kind of standardize some of the interpretations so across sites you have less noise. It was to power it to 90% to show that the MR finds 9 extra invasive cancers per 1,000. It was about a 1,500 patient study. We accrued a year early because women were so interested and heard about the study that we accrued at the end of last year. We're just now looking at the data. We're also doing some exploratory, looking at genetic profiling of the cancers to see if the MR cancers are more biologically significant than the tomo. So this is just exploratory, but our premise is that the vascular-based screening finds more significant cancers, higher-grade cancers. We also looked at some experimental, some sites did some ultra-fast scanning during the first 30 seconds to see if this ultra-fast perfusion, we're going to do that in a reader study later, but having this quick perfusion in the first 30 seconds imaging, can that help differentiate benign from malignant, where cancer's enhanced, let's say, at 20 seconds, and if it doesn't enhance by 20 seconds, it's more likely benign. Just another technique to add to this whole concept of abbreviated MR that doesn't cost you anything, and that might improve the specificity. We had a mixture of, the NIH likes to have not just ivory tower academic sites who are experts, but also community sites so that they know this test can work in anybody's hands across the country. So we had a nice mixture of sites. We don't have all the details, and it's not published yet, but it's looking like in terms of total number of cancers, the MR in that one round found at least 2.5 times as many cancers and twice as many invasives, probably. So we're going to publish the study in the next probably 3 to 6 months. The study's coming out. But so far, the results are looking about what we thought it would show, about 2.5 times the cancer detection rate. So if it's 2.5, that comes up to where do we go from here? If it's 2.5 times the cancer detection rate of mammography, we're already working on the next study after the phase 2, is a pivotal study of phase 3, where we would randomize women to mammography and ultrasound every year versus an MR, 10-minute MR every other year as your only screening test, a 10-minute MR, that's it. And maybe it could go every 3 years depending on risk. And so that's where we're at right now. I think it's promising work. And so in summary, I think right now our methods in the United States are fairly inefficient: mammography plus whole breast screening ultrasound with about a 5 to 7 cancer per 1,000 detection rate and about a 20% interval cancer detection rate. MR may be a much better, more efficient test, a 10-minute MR versus whole breast screening ultrasound every year. And eventually we may look at MR and including non-contrast methods as MR as the only screening method and no longer doing mammography ultrasound. And that's our direction. Thank you very much.